All right, good morning, everyone. It is time for what's quickly become my favorite grand rounds of the year. Head Talks is an annual tradition that began 8 years ago under Dr. DeBonis. The next hour will feature 4 talks given by residents talking about ideas in the field of psychiatry that they're most passionate about. The talks are limited to 10 minutes each, which is an incredibly difficult amount of time to stick within. But each of these residents has put a lot of time, practice, and effort into polishing their talks to deliver some really fantastic content in a short time frame. These topics do tend to generate a lot of questions and discussion, but in the interest of giving everyone enough time to present, we're going to hold questions for all 4 speakers until the very end. But feel free to put them in the Q&A in the meantime. When you do submit your questions, please make it clear which speaker you're addressing them to. All right, and to start off today's program, I'm extremely proud to introduce Dr. Alex Cohn. I had the privilege of interviewing Alex as he applied for residency here, and I remember being struck by just how incredibly thoughtful and mature he was in his responses to the questions that he was asked. I knew at that time that he would make a really fantastic resident here, and he has not in any way proven me wrong. Alex is not only an incredibly humble and endearing individual, but also a creative force to be reckoned with, as you'll see in his head talk today. One of my favorite memories from the past few years is watching Alex perform as a contestant on Jeopardy, which highlights his extensive interests and abilities outside of just his clinical work. So in the spirit of honoring his time on the show, I wanted to do the rest of his introduction as a Jeopardy clue. So in my best Alex Trebek impression, a graduate of both Harvard and Tufts, this multilingual resident has appeared on both Jeopardy and Family Feud. So now, if you'll turn your attention to Alex's talk, I think we'll be able to answer the question of who is Alex Cohn?
Wow, thank you so much, Dr. Halt. That was an amazing introduction. So for my presentation, it is on, so it's entitled Playing Possum on the Evolutionary Basis of Catatonia. So why possums? So this kind of goes back to actually my intern year, the first time I saw a patient with catatonia. I kind of walked into the room and I saw them kind of not really reactive. Apparently their whole medical workup was within normal limits. So the thing that first went to my mind was that person is just playing possum. And then growing up, my mother's family is from Kansas City. So we have some folksy idioms that we use. And one of them is just like, you're playing possum, which kind of means that you're pretending to not really respond. Particularly it was used for me when I was not wanting to go to school, kind of pretending not to wake up. So that was kind of what went through my mind. And then kind of as I went through residency, I got to know hey, catatonia is absolutely not playing possum. There are deep set issues and very complicated symptoms. But it kind of still tied back to the question of playing possum, because the idiom comes from these cute creatures, possums, that indeed in nature they do get really surprised and do play dead. So my kind of question was, is that behavior of the possum kind of preserved in us and then kind of gets inappropriately preserved in catatonia? So kind of to do that, I'm going to start the talk just by showing a video. So this is in San Jose, California, which is actually my hometown. I did not film this video. My mother, when I showed her this, she asked me, did you go bother a possum? I did not. This is just on YouTube. So while this is going on, I also want to go through one of the main rating scales of catatonia, which is the Bush-Francis Catatonia rating scale. So here we have a possum. It's just walking by. And then we'll move forward a little bit. And then we can see it's trying to run away. And then it kind of realizes oh, it can't run away. And then this is where it just stays still. So if we go to the Bush-Francis scale, there you go, it's kind of moving a little bit. So some of the criteria we have, is there any excitement? Possum's not really showing much excitement, but immobility and stupor, I would say that's definitely the case. Mutism, so I was going to include a video of possums hissing. They're very verbal. This time it is not, so no speech. Is it staring? That seems like a fixed gaze to me. So posturing and cataplexy, is it kind of spontaneously maintaining sort of strange posture? If we move forward a little bit, So we can see.
Hey, Alex.
Yes.
Sorry to jump in. We can't see the video or the slides if you're sharing.
Oh, it's not? Oh,
Yeah.
uh-oh. Share the screen.
Okay.
There we go. Is that working?
Thank you.
Great.
Yes.
Okay, so going back a little bit, Possum running away. Here it is, frozen. And we have the Bush-Francis scale right here. Okay, so then if we move forward just a little bit quickly in terms of posturing, we have very bad behavior on the part of the people filming this. So we do have a bizarre posture. I would say that's a grimace. And then we have kind of the other symptoms that we know of catatonia, the sort of more behavioral ones that they don't really test with this possum and that you don't really see, because this is certainly not like an excited catatonia. So I think kind of from all of that, it meets about 15 points on the Bush-Francis scale. And per DSM criteria, that actually does count, because you need 3 criteria. So the question is, like, is that catatonia? But the complicating factor is that for us, I mean, catatonia is only clinically relevant if its duration is fairly long. For ICD codes, I believe it's like a 2-week period of having these symptoms. So it's not really catatonia because the possum just sort of walks away. So really kind of what we have, a better way to describe it is tonic immobility, which is kind of preserved in nature, seen in different animals. It's called also thanatosis. We see it in sharks. If you rub their tummy, they kind of get hypnotized. Same thing with chickens. And it's a behavior that's thought to be evolutionary beneficial because it prevents predators from eating an animal. If they kind of see that this thing is dead, they're not going to eat it. Most predators prefer live creatures. And indeed, the possum also is known to defecate, make really bad smells, and kind of pretend to be a rotting creature, which prevents it from getting eaten. So for me, my question really was now, is catatonia the same thing as tonic immobility? And in terms of seeing that, in my research, I saw that tonic immobility is actually something that's seen in people, primarily in kind of cases of extreme trauma, especially sexual trauma and sexual assault, that you do see patients reporting completely freezing up, not being able to move. So there is kind of some basis for it being seen in humans. But to my research, so 1964, banner year for possum research. An EEG was done actually in Los Angeles. And I know Janice Cho is actually on EMU rotation, but I'm not going to have her read this right now. But basically, we see before, during, and after the possum was scared. And I'm not great at reading EEGs, but I can tell you that their findings were there is no difference. It didn't seem like there was any real response that the possum had in terms of its EEG. But as I said, it was a banner year. There was another study in Texas, also 1964, that showed that maybe there was a little bit of activity in the amygdala right before it sort of went into the behavior. But otherwise, again, nothing that major. So in terms of catatonia, we don't really see in people like a lot of changes in the EEG. So this doesn't really help us that much, maybe a little bit, but we got that. In terms of physiological response, we have to go to the 1980s. So we look kind of at heart rate and breathing rate for a possum. So right here we have when it's scared. And then when it's scared, the heart rate suddenly drops, breathing also drops. So it's interesting because in catatonia for people, normally we actually see kind of autonomic instability. A lot of times we're worried about increased heart rate. So this seems a little bit not like human catatonia. And then the other interesting thing to notice is that with the possums, when they gave them atropine, the heart rate was maintained. So that kind of indicates that there is a lot of parasympathetic activity that's going on, kind of mediating this. That said, even though they gave the atropine, it didn't actually change the behavior. So there's more things going on. The possum continued to play possum. And then the other kind of way that I wanted to approach this is, what about responses to benzos? Because for us, that's like pathognomonic for catatonia. Unfortunately, couldn't find any studies of giving benzos to possums, but because the behavior is preserved in nature, in 2 studies, so for chickens and then for guinea pigs, benzos actually increased the length of the tonic immobility when they scared it, which is actually the opposite of what you'd expect. So kind of in those regards, it doesn't quite seem like things are the same. Other way to approach it is in terms of neuroanatomy. So for tonic immobility, kind of what I mentioned with the EEG, that you see activity of the amygdala, and then more research based on kind of lesioning different parts of animal brains, is that if you lesion the amygdala, if you lesion the periaqueductal gray, it stops the tonic immobility reaction. Moving over to human catatonia, which is a lot more complicated and also a lot more debated. It's kind of viewed that it's more higher cortical structure. So one of the major researchers in this, Northoff, kind of has pointed to the orbital frontal cortex as being hypoperfused in people who have a tendency to have catatonia. And his general postulation is that that kind of goes back on the motor regions, which leads to the basal ganglia and then causes the motor dysfunction. In none of the research could I really find a connection between these two circuits. So the 2004 article by a psychologist called Moskovitz tries to argue that perhaps these things are actually interrelated, that maybe these are higher cortical processes that then are inhibiting this sort of more basal fear reaction. But kind of based on the other things I found, not responsive to benzos, symptom, and then the physiological response, I don't know really how convinced I was of that, but it is interesting. And then just one interesting thing too is that there's something called the encephalization quotient, which is just how much brain an animal has compared to its body size. So human is over here, and then possum is way, way over here, all the way on the left. So maybe it is kind of a preserved thing. So kind of, is there a real answer to this? One thing that this kind of led me to more than anything else, so I mean, the great thing about patients, unlike possums, unlike chickens, unlike guinea pigs, is that we can talk to them. It's really great. And the interesting thing was, even though I found decent information about possum EEGs, there wasn't like a ton of recent data about like actual subjective experience of patients. So I did find like one article that really kind of dug up more historical things. So this is a French patient in 1862 who said they imagined that both their parents were dead, their native city had been flooded. They lived in continual anxiety. They were filled with self-loathing. They were convinced that people wanted to drown me, and just felt like he was going to be crushed on the railroad tracks that passed nearby. One kind of study in 1921 at a state hospital, out of 100 patients with benign stupor, which back then is kind of the wording for catatonia. 18 had fears of being killed, 15 had just sort of vague fears, 10 of castration, 5 of homosexuality. It's the 1920s, so probably a more frightening experience. And then 5 of being buried alive. And then kind of the only recent subjective experiences we see are, again, Northoff, the more the neuro researcher, showing that there is kind of a repetitive theme of blockade of will and anxiety, but nothing else major. And the Northoff is even in German, so it's really kind of hard to get at that information. So is there an answer? Is catatonia the same thing as tonic immobility? Same thing as what's going on with the possum? It's hard to say. We don't really have the neuro evidence to back it up. Some similarities, some differences. But to me, I guess, for my journey in going through this, I went through possums, through chickens, through guinea pigs, and ultimately it brought me back to people and patients. And it really was the patient experience that kind of informed me of, yeah, this is a really anxiety-provoking, scary experience. And even if I don't have like an answer to, yes, is it a basally preserved evolutionary experience? Like for my clinical experience with the patients, it's just going to be kind of knowing and having an empathetic relationship, which is funny because the very beginning of this kind of began with a failure of empathy, of me seeing like, oh, that patient is playing possum, they're faking it, into sort of a more complex understanding of this could be extreme anxiety that's sort of paralyzing. So that's kind of my journey, which was both interesting and emotionally rewarding. So yeah, thank you so much.
Right. Thank you, Alex. That was really interesting. It is my pleasure to introduce our next speaker, Dr. Tiana Raphel, our very first PGY1 resident to be a speaker in this program. I am not at all surprised that she signed up to give this talk amidst a very busy intern year, given her long track record of leadership and initiative. Tiana received her undergraduate degree in biomedical engineering from Harvard University, followed by her medical degree from University of Texas Southwestern with a distinction in medical education. She has been involved in exciting research across many disciplines, including development of an algorithm to better advise medical students on specialty fit using a personality inventory, as well as a study evaluating THC metabolism in youth, and a project building decision models for cancer screening and treatment. In addition to her impressive scholarly track record, she has shown as a leader within her medical school and at the national level, particularly with regards to addressing health disparities in medicine. Tiana also happens to be a dedicated educator who has held many different teaching roles and hopefully will continue to grow her passion for teaching throughout residency and beyond in her career. I know that I am looking forward to learning more from Dr. Raphel today with all of you as she shares her talk on reimagining Freud, how personality identity ties into psychiatric innovation. Please join me in welcoming Dr. Raphel.
Oh my gosh, thanks so much for that intro. I'm excited to talk with y'all today. I'm actually gonna share my screen now and we'll get started. So like Dr. DeBonis stated, today I'm going to be talking about someone that I think a lot of us have heard about, Freud. The talk is titled Reimagining Freud, How Personal Identity Ties into Psychiatric Innovation. And I want to start by showing a clip of this video from an organization called Black Psychotherapists Speak. I think it will be a really good intro and really ease us into the discussion.
I think psychoanalysis struggles from many misperceptions, one of which is the fantasy that people are all the same.
But there is this aspect of psychoanalysis which I think can somewhat be attributed to Freud and Freud's attempt to flee his Jewishness. It is to assume that people are sort of generically the same.
He wanted psychoanalysis to be universal and not just a Jewish idea.
However, the generic human being happens to be a white male.
And yes,
So I wanted to share that to kind of get the discussion going. The learning objectives that I hope that we're able to better address today include learning what cultural milieu did psychoanalysis actually germinate from? How did Freud respond to this milieu? How did him developing a theory as universal as the Oedipus complex allow him to manage this cultural and social milieu that he was growing in? And finally, what can we learn from the ramifications of Freud's approach? So 1896 was a really big year. It was the year of the first Olympics in Athens. It is Olympic season now. You should check out ice skating if you haven't recently. But it was also the year that Freud came up with the term psychoanalysis. He was living in Vienna, Austria, and I think that his location really influenced, what he was exposed to, what pressures he was under. Also, 1896 is right when the rumblings of World War I were starting. And I think this really ties into something that the video addressed a little bit, which is that Freud grew up in a Jewish family. He had many siblings, sisters and brothers. And this identity and this kind of cultural association for him was something that was kind of unavoidable for him. And I'll discuss a little bit more. But this was kind of the timing and what was going on when Freud was coming up with psychoanalysis in the beginnings of that. So what evidence do we have from Freud's, lived experience? He's not here with us, but he wrote a lot of great books and he engaged with a lot of others. And from that, we can get a sense of what his lived experience was. So Freud was found to say, my background as a Jew helped me to stand being criticized, being isolated, and working alone. He certainly faced anti-Semitism during his medical career, during his developments of his ideas, and certainly in Austria during this really heated time in history. Furthermore, even as a child, we have evidence that Freud was thinking about his identity, his cultural background. He was known to say, in the higher classes at school, I began to understand for the first time what it meant to belong to an alien race. And the anti-Semitic feelings from the other boys warned me that I must take up a definite position. During this time in Vienna, it was also known that Jews were kind of thought of as the Negroes of Vienna. Psychoanalysis was thought of as a Black thing accordingly. And so these were the kind of labels that were trying to be put onto his work. And in his works, The Interpretation of Dreams and Jokes in the Relation to the Unconscious, there is some discussion from him in terms of the anti-Semitism that he faced. So we know Freud was thinking about this background and the way that affected him. We also have evidence that he was thinking about socioeconomic status as well. So in The Disturbance of Memory on Acropolis, Freud writes about how he had this experience where he went to the Acropolis and had a neurotic moment where he dissociated and did not really believe that he was there. And in discussions at this time, he did attribute some of this feeling due to concerns of where he came from. He said, I started in poverty and I started so low. I could not believe that I was here in this moment experiencing this grand view. And he did not know, or he was not sure that he would kind of make it to this moment. We also know through his work, Inhibition, Symptoms, and Anxiety, that he was starting to think about race and socioeconomic status a little bit, in that he was referencing that children who were white tended to have different manifestations of neuroses, or he thought it was more common. So he was really trying to tease out, the contributions of these things and was actually speaking about them. However, I want to go to see what, Freud ultimately came up with to describe this experience, his neuroses, his dissociation that he had on the Acropolis. He had discussed all these different influences on him, but what did he ultimately use to describe and encapsulate neuroses in general? So a lot of us know about the Oedipal complex. It's very famous, probably seen it in like Family Guy, lots of TV shows. It really got around, and it's a really universal idea based on a myth, and it describes this phenomenon by which Freud believed that children's sexual desire for their opposite sex parent and hatred for their same sex parent led to conflict. And the way to overcome that conflict was to identify with the same sex parent. However, if people did not end up identifying with the same sex parent, he described the development of neuroses. So this is what he kind of used to underpin what was a good way to describe why some people had symptoms of neuroses, or that tracks more with anxiety nowadays. And he took this very mythical idea, this universal concept, and applied it to describe and explain what he was experiencing and what many other people experience. So when thinking about the ramifications of that, so we have this idea, neurosis, and it's affected a lot of ideas of what could have gone into what led to it. I know heredity is something that we think about a lot. During that time, there were prejudices and ideas that people who were Jewish were more prone to mental illness. So that was an idea going around at that time. There was this idea, and Freud expressed himself, how growing up in poverty and how that affected his neurotic experience on the Acropolis. We also had him discussing how race might have affected neuroses in children, and then his religion as well, how that might have played into neurosis. So this is all these things that he kind of spoke about contributing to the development of neuroses, but what actually did he use to describe that? He encapsulated it in a way that was more simple and more universal, and really tied it to sexual repression. And let's think about what, the pros and cons of doing that are. So the pros are, Freud was under a lot of stigma during that time. And this allowed him to finesse his way from that stigma, these associations and names attributed to psychoanalysis, to something that was more apolitical, something that could avoid eugenic ideas about others. However, a con to think about, and which I think is really relevant, is that there was no carved out space to discuss how race, ethnicity, and socioeconomic status might have affected the development of neuroses. And being apolitical is something that could be a con as well. You can avoid conflict, but sometimes, there needs to be a discussion that's had. So I want to take us again and hear back with Black psychotherapists speak.
I had an analyst who was exceptionally bright, exceptionally on, but when it came to the issue of race, he was thoroughly blocked. He said to me, in his career, he had only treated one Negro. That was his word, one Negro, okay? Which I smiled. He told me, he said, the treatment didn't go well because all the guy wanted to do was talk about race. I couldn't get him off race, okay? I smiled again.
One of my teachers was one of those old white guys who could not hear the word race. He used to take his cane and beat the table.
There has been near violent reactions to the things I say about the way racism, culture, and economic inequality affects my life and my work with my patients. And I presented in London at the Freud museums, and I talked about race. One psychiatrist grabbed me by my arm and wouldn't let me go up the steps.
So how do we proceed in a world where the realities of racism and sexism are kind of affecting our patients and their lived experiences in the context of this framework that was already built long ago that had many pros and also some cons? Well, I just want to leave us with this idea that, we are at UCLA. Someone could be the next Freud here. We are developing new ideas daily. We're doing really amazing research, innovating, patient care. And because we are the next Freud, we could be the next Freud. What we do matters. And so I would just encourage us to think about, when we're innovating, ask ourselves two questions. Who am I building this for? And secondly, do I understand my biases well enough to not bake them into what I'm creating for the future? Thank you so much. Here's some references. And then I have some acknowledgements. Dr. Helt, Dr. Moore is my PCFA mentor, and she talked with me, the clinical education lunch lab, listened to this talk in its early infancy. And then Amir Collison provided emotional support. And then Keenan actually showed me the video that I played for y'all. Thanks.
Thank you so much, Tiana. That was a really great and very thought-provoking talk, so thank you. Our next speaker today is Dr. Ashley Hite. Like Alex, I had the honor of interviewing Ashley when she applied for residency here. On paper, I was struck by just how incredibly impressive Ashley was. She had a background in philosophy, neuroscience, and psychology, and then went to the University of Chicago Pritzker School of Medicine for a medical degree. But I think in person, I was even more blown away. Ashley was just an absolute superstar, and even in the short time we spent together in the interview, her positive spirit and boundless enthusiasm and really deep desire to affect change in the world around her were all immediately apparent. Since coming here for residency, she has really delivered on all those promises. She's one of our Justice, Equity, Diversity, and Inclusion Chiefs this year, and even somehow found the time to create a program providing mentorship and guidance to students from underrepresented backgrounds on navigating the path to medical school. What I didn't learn until just this year, however, is how gifted of an educator Ashley is. In fact, before coming to medicine, she actually taught middle schoolers, and I honestly cannot think of a harder task in the world than convincing a bunch of preteens to pay attention to math and English. But rather than just take my word for it, please join me in giving Dr. Ashley Hite a very warm welcome for her talk.
Thank you so much, Dr. Helt, for that. And I'm actually going to be doing a talk dealing with adolescents, given that I was a teacher. So let me share my screen really quickly. Alrighty, so again, thank you. My name is Ashley Hite. I'm a third-year resident here. And today I'm going to be talking about the truth behind vaping and its impact on adolescent mental health. So just today, I hope to help you all kind of understand the effects of vaping on the physical and mental well-being of an adolescent or young adult, be able to identify psychiatric illnesses linked to vaping, and be able to effectively educate patients and parents on the dangers of vaping on the developing brain. So I'm going to start with a quick clip of just seeing what's been in the news recently.
Kids are just constantly being bombarded with media messages.
When the Juul was introduced, it changed everything.
Tonight, the rise in teen vaping and the impact it is having in school classrooms. Good evening, and thank you for joining us. I'm Amanda Starantino.
And I'm Mark Mullins. The U.S. Surgeon General has already declared vaping a national epidemic among teens, and Indiana schools are experiencing that epidemic firsthand.
RTV6's Stephanie Wade talks with one school district taking action to roadblock vaping in their schools.
School resource officers say they find students vaping in the bathrooms, in the classrooms, and even at home. This year alone, they've written 26 citations related to vaping.
It went from 1 or 2 tickets a year to 26 in a year, and this year's not over.
Exciting flavors from...
So this one is called Rock Candy Mystic.
Okay, so as you can see, vaping has become an epidemic, and this is not just limited to this small town in Indiana, but is actually pretty widespread across the country. So for those of us who don't know, what is vaping? So e-cigarettes, or otherwise known as electronic nicotine delivery systems, are battery-operated products that deliver nicotine via inhalable aerosols generated from generally a nicotine-containing solution. So when one is using one of these products, it's what we know as vaping. It provides a taste and inhaling sensation similar to smoking an actual cigarette, and vaping has actually become extremely controversial given the rise of use in adolescents and young adults over the past decade, and concern that the role these products may play in initiating and perpetuating nicotine dependence, along with detrimental effects it may have on brain development. And as you can see in the diagram, first generation e-cigarettes were made to actually look like cigarettes, but the newer generation ones are more advanced to be more appealing, and some resemble pens, USB drives, and other things kids can easily put into their backpacks and have them blend in, with the most common brand actually being Juul. And as you can see, they have very colorful, interactive ads that are very appealing to our young teens. So I'm going to do a quick poll. Asking approximately what % of US adolescents do you all believe think that e-cigs do not contain nicotine? All right, so you should see it pop up on your screen, and you can go ahead and answer. All right, and as you guys can see, most 44% of people said 65%, and that actually would be correct. About 65% of US adolescents believe e-cigs do not contain nicotine. With that being said, kind of thinking about how did this happen? So over the last 20 years, there actually was a decrease in teens smoking what would be known as combustible cigarettes. In 1991, about 70% of teens were smoking, down to in 2017, only about 30%. At that year, 2017 to 2018, unfortunately, people stopped using the combustible cigarettes and it jumped to vapes. That 11.7% to a 20.8% jump is equivalent to about 1.3 million teens. So as we can see, this is no small issue. It has become an epidemic, as stated in 2019, the number increased again. And then you might be a little confused. The data in 2020 and 2021 is a little skewed just because of COVID. Kids weren't in school and weren't able to have access and get away from their parents as frequently as they were when they were going to school. So those numbers aren't as realistic as the 2018 and 2019 numbers, just to give a heads up. Okay, so, what are some of the health risks of vaping in adolescents? Many studies have shown that about 40% of adolescents did not consider Juuls to be e-cigarettes at all. And some studies also have noted that about 63%, like we stated before, did not know Juul pods contain nicotine at all, when in actuality, e-cigarettes actually contain higher concentrations of nicotine over a combustible cigarette. So teens have also been known to be shown to be more susceptible to addiction. We know that nicotine addiction often originates in adolescence, with studies showing that close to 90% of adult daily smokers started smoking before the age of 18. Thus, e-cigarettes are effectively helping to create a new generation addicted to nicotine that we have spent so long trying to reduce. And unfortunately, a lot of long-term effects still remain unknown, but there have been some links seen between vaping and mental health. So another quick poll, which of the following do y'all think is a risk associated with vaping? Okay, I'm going to share the results. And I want you all to take a quick look. It's about 43% increased future use of substances. Some people said development of mood symptoms, and lesser said increased impulsivity and issues with executive function. Okay, so I'm not going to answer the question quite yet. I'm going to let you watch a clip, and hopefully that will answer some of the questions at hand.
My name is Katie Jo. I'm 11 years old and I started vaping in July.
I'm Caitlin. I started vaping 3 years ago.
My name's Isaac and I started vaping at 17.
I'm Chloe. I'm 17 and I started vaping when I was 15. As soon as I started vaping, I started having panic attacks. I thought it just affected your body and not your mindset.
It was making me feel less than who I was. My confidence was just dropping.
I thought vaping could be a stress reliever because most of my friends were doing it and they were telling me how it helped them through school and homework, and I was trying to make a decision of where I wanted to play college football at, and I was just extremely stressed, so I picked it up and tried it.
Vaping does not make you relaxed. If anything, it makes it so that you are more anxious. At first, I didn't think it was addictive. I thought I was kind of stronger than it, but soon I realized it was holding kind of a power over me. I would leave class and use it, and I was always craving more and more. It was never enough.
A lot of people assumed I was happy all the time, but once I got home, I would go to my room and it'd just be depression and sadness and loneliness, and I felt like no one was there for me.
Well, I started isolating myself from a lot of people, friends, family, in the world.
So that just, in a short clip, just lets us see into the mind of teens and how much of an impact this can have on their mental health. And to answer the poll question,
Hi, it's Caitlin.
We see that it affects all of the above. It was noted to have an effect on increased impulsivity. There's an animal study that showed that exposure to e-cigarette vapor during times of rapid brain growth, so times like adolescence, can cause hyperactivity and impulsive behavior change. Another study looking specifically at the teen population found increased risks of physical fighting and attempted suicide. It also had an effect on issues with executive function, like memory, concentration, cognitive deficits, much like you can see in the clip. Kids are struggling in school just from simply vaping. Increased risk of development of depression and anxiety, and also an increased risk of substance use, which is one of the scariest, I think, for me to think of as well. And just to ask you all, what do you think, which substance is associated with which substance is most associated with increased future use in teens who vape? Okay, so as you all can see, the top ones are actually marijuana is the most likely. Yes, those who vape are 4 times more likely in the future to use marijuana. The next one would be cigarettes, actually, combustible cigarettes. They're actually 3.6 times more likely to use cigarettes if they vape. And then alcohol would be the next one. They're actually a lot more likely to involve themselves in binge drinking if they are vape users. So as we can see, the top ones are alcohol, cigarettes, and marijuana. And so what can we as providers do? First, I'd say keep up with the facts and trends. Being up to date so we can educate our parents and teens, which is even more so important in our population as psychiatrists, given our patients normally are presenting with some underlying mental health issue. So it would be deemed to be at even higher risk of developing higher stress, depression, and substance use, particularly marijuana. And remember, about 40% of adolescents in the US still consider e-cigs to be less harmful than traditional cigarettes. And most of their information is gathered from social media and peers. So we want to have these open-ended discussions with them in a particularly non-judgmental and culturally sensitive manner. And parents need the education as well, as many rely on their schools to educate their children or even educate themselves, and very little communication is done on this topic. And fourth, participating in advocacy work. That is how we got the sale of e-cigarettes to be illegal to those less than 21 years old. So continuing to do work like this will help us to make big change and progress. And lastly, developing and conducting more research as more longitudinal studies of e-cigarette use is needed in order to better understand these effects that it can have on the mind and body. So I know we'll do questions later. And here's my bibliography, and thank you all for listening.
Thank you, Ashley. Love the poll questions. Wonderful talk. Learned a lot. Thank you so much. It is an honor to introduce our last speaker for today, Dr. Anne Crawford-Roberts, a fourth-year psychiatry resident here at UCLA and chief resident in community and global psychiatry. Anne studied anthropology and international relations at Brown University, received her medical degree at the Icahn School of Medicine at Mount Sinai, and her Master's of Public Health at the Harvard T.H. Chan School of Public Health. Anne came to UCLA with an impressive record of service, advocacy, and leadership, including research on the proposed Affordable Care Act repeal, which led to publications in the press and her work being cited by senators during media interviews and on the Senate floor. Luckily for us, Anne brought her passion for advocacy and leadership here to UCLA, where she has worked to make our department a better place in many ways, including founding and facilitating the UCLA Psychiatry Department's anti-racism learning groups. Her research interests include the social determinants of mental health and mental health service access, which aligns with her national leadership through work in the AAMC and APA as a second-year leadership fellow. On a personal note, working with Anne over the past 4 years has been a true joy. She's an outstanding clinician, and I am continually inspired and learning from her. I am excited to do so again today as she shares her talk on grief during the COVID-19 pandemic. Please join me in welcoming Dr. Crawford-Roberts.
Thank you so much, Dr. DeBonis, for that kind introduction. As she said, I will be talking today about grief in the COVID-19 pandemic. Last Friday, the US death toll passed 900,000 individuals from COVID-19, which is the highest in the world. This is also the single highest mortality event in US history, exceeding all military conflict and prior pandemics. And with every COVID death in the US, there are approximately 9 family members bereaved, and that's not including non-kin loved ones. Again, the scale is immense. 8.1 million Americans are bereaved from the death of family members due to COVID. The scale of deaths during this pandemic is enormous, and beyond deaths, the disruption to life is immense. As we approach 2 years into this pandemic next month, how do we make sense of this magnitude of loss? How does it impact the bereaved? And what of the impact of non-death losses during COVID? Losses of milestones, of community, of normalcy. My aim today is to introduce 2 categories that can help us make sense of grief in this time: complicated grief and disenfranchised grief. And people can experience both at the same time, or one or the other, or neither. I hope by the end of this talk, you can define these terms, apply them to the pandemic, identify them, and describe 3 tools that can be used clinically. And I also want to note that we as psychiatrists and psychologists experience grief ourselves. We're not immune from grief. Overall, my hope is that this talk elucidates dynamics that we know from our own personal and professional experiences so that we can better support ourselves and our patients. First, complicated grief. Grief itself is the response to a significant loss and includes a separation response and a stress response. Complicated grief is a grief that is more severe in intensity or duration and that impairs daily functioning. The core symptoms of complicated grief are longing and yearning to be with the lost person and sadness about the death. Other experiences include persistent images or thoughts of the deceased, an inability to accept the loss or a persistent disbelief that it has occurred, ruminations, especially about the details of the death, avoidance of reminders of the loss, or frequently turning to reminders of the deceased, including images and objects. And it's not uncommon for people to oscillate between avoiding reminders and seeking reminders out. And finally, the inability to imagine a future without the deceased. Risk factors that are relevant to the pandemic include multiple losses at the same time, the context of the loss, and inadequate social supports. A note on terminology. Complicated grief has been the longest described phenomenon, which has been formalized into two diagnostic categories: prolonged grief disorder in the ICD-11 and persistent complex bereavement disorder in the DSM-5. In our current context, there are multiple factors interfering with grief adaptations. First is the inability to say goodbye to a dying friend or family member in person due to travel restrictions and hospital and nursing home policies restricting visitors. This fact early in the pandemic shocked us and now has become normalized. People are dying alone, and the bereaved are losing an important chance to say goodbye. In addition, travel restrictions and social isolation are causing delays or cancellations of important grieving rituals, such as funerals and burials. Usually these rituals and the social support surrounding them help the bereaved adapt to their loss. Now, the bereaved are more likely to be deprived of mourning rituals. Oh, sorry, I skipped ahead there. Deprived of mourning rituals, of the physical presence of their loved ones, and of social support that they need to adapt to the loss. Beyond specific mourning rituals, social isolation at large is leading to diminishment of social support. Next, many COVID deaths are occurring quickly and suddenly. This contributes to complicated grief and makes it more likely that the loss will be traumatic. Beyond this, the larger pandemic dynamics may contribute to anger, anxiety, and guilt. For example, unfair access to treatment may produce anger. The erratic nature of survival versus death may contribute to survivor guilt, and there may be significant anxiety about COVID transmission to other loved ones. Further, the sheer volume of loss at this time means a family, community, or workplace may be grieving multiple people at the same time. Social support is stretched thin when so many people are grieving so many losses. Just as hospitals have been overwhelmed with COVID patients, communities can be overwhelmed by the level of loss with social support resources strained. Now shifting to disenfranchised grief. It is the grief experienced by those who incur a loss that is not openly acknowledged, publicly mourned, or socially supported. This term was conceptualized and defined in the 1980s by Kenneth Doka, who studied people who would say, quote, "It was as if I didn't have the right to grieve." Society defines who has a legitimate right to grieve and for what types of relationships. But there are losses outside of those traditionally defined ones, as there are important relationships outside of those that are typically recognized. Those experiencing disenfranchised grief grieve in private without receiving social support, verbalizing losses, or receiving sympathy from others. Disenfranchised grief can occur in kind of a few different categories. One category is when the relationship itself isn't acknowledged or valued, like the death of an ex-spouse, a friend, or a gay partner in a homophobic community. Disenfranchised grief can also occur if the death itself isn't acknowledged or shared publicly, such as stigmatized deaths like suicide or substance overdoses. Disenfranchised grief can also occur when the loss itself isn't acknowledged or valued, such as a miscarriage or a non-death loss. We can apply disenfranchised grief as a lens through which to view the multitude of non-death losses that have occurred during this COVID pandemic. There have been the losses of celebrations to mark major milestones, graduations, weddings, birthdays, births. There's been the loss of plans, of hopes, the loss of ritual, of hobbies, of religious worship, of children's sports, and of in-person schooling for much of the pandemic. There's the loss of normalcy and of community. These losses are likely to cause disenfranchised grief when people do not verbalize them to others, feeling ashamed to publicly grieve when others are grieving deaths. Individuals may not acknowledge the losses themselves, rationalizing that their loss is not significant as compared to those of others, and minimizing their own suffering. And when grief is expressed, if others don't acknowledge or value those losses, depriving those grieving from social support and sympathy, that can also contribute to disenfranchised grief. Our community here knows many non-death losses. The loss of an in-person graduation ceremony for PGY4s and our in-person retreat in 2020. Many of our residents lost their in-person medical school graduations. There have been retirements and major accomplishments marked by virtual or drive-by celebrations instead of in-person ones. And there's been the loss of opportunity to meet other residents and faculty in person to build connection and community. I invite you to take a moment now to reflect on the non-death losses in our community and in your own life, and ask yourself if you've grieved these losses, and if you felt you had the right to grieve them. I'll shift over now to talking about interventions. First, for complicated grief, there are two screening tools to assist in its assessment: the Inventory of Complicated Grief and the Prolonged Grief 12 questionnaire. Comorbid depression should be assessed, as should suicide risk and substance use, as complicated grief increases the risk of suicide, substance use, and other high-risk behaviors. There are two types of grief-specific therapy, both lasting 16 weeks, and these have both been well studied. One is complicated grief treatment, which focuses on the loss and restoration of functioning, and interpersonal therapy, which focuses on interpersonal problem areas, including grief, with the aim of improving mood. In one head-to-head study comparing the two, complicated grief treatment had a greater responsiveness, but in another head-to-head study, they had similar outcomes. Other studies of non-grief specific therapies have found two useful targets for treatment in grief: behavioral activation and reduction of avoidance. Pharmacologically, the data is lacking. There are no RCTs and no FDA-approved medications for complicated grief. There have been 5 open-label studies suggesting responsiveness to antidepressants and not to benzodiazepines. There is a role for concurrent pharmacologic and psychotherapy treatments. In a study of complicated grief treatment, patients receiving antidepressants had higher rates of completion of the therapy compared to those not treated with antidepressants. If grief-specific therapy is not available, there's still an important role that we as psychiatrists and psychologists can have in helping grieving patients. We can all do the following 10 things with our patients. 1, active empathic listening while eliciting a history of the relationship with the person who died, the death, and the patient's grief experience. 2, grief monitoring, which is a simple procedure that takes about 5 minutes each day. 3, psychoeducation about acute grief, adaptation to loss, and prolonged grief, as well as education about COVID-19 to lessen self-blame and survivor guilt. 4, encouraging creative ways to safely honor traditions and memorialize the deceased. And 5, if the loved one is still alive and has not yet passed, encouraging communication of goodbyes. 6, encouraging creative ways to enhance positive social connections. 7, behavioral activation, helping the patient find ways to build in activities as they begin to re-engage in life without the deceased. 8, inviting the patient to talk about how they learned of the death. 9, encouraging the sharing of positive and negative memories of the deceased. And finally, 10, supporting the patient to approach avoided reminders of their loved ones, such as avoiding prior shared friends or activities. The treatment of disenfranchised grief is not as well studied as complicated grief, but we can borrow from many of the same principles in the 10 points above. If disenfranchised grief is grief that people feel they don't have the right to have, the important intervention is to give individuals the right to grieve. Active empathic listening and validation of individuals' experiences of loss are key. Encourage them to engage creatively in rituals and milestones that have been missed, and in other activities that help them make meaning, create narrative, and recreate a sense of community and connection. I'll conclude by quoting from a gem of viewpoint piece by 3 psychiatrists at NYU. The solution is a diligent focus on families and communities to creatively restore the approaches by which they have managed tragedy and loss over generations. History has shown that societies recover from such devastation when leaders and members are joined by a shared purpose, acting in a unified way to facilitate recovery. In such societies, there's a shared understanding that its members must care for one another because the loss of one is a loss for all. Among my references, I just wanted to highlight the first one, which is the APA's COVID-19 pandemic guidance document. I found that very helpful. So I hope you're now able to define complicated grief and disenfranchised grief, recognizing people can experience both at the same time, apply these to the pandemic, identify them, and describe 3 clinical tools to use with grieving patients. I want to thank Dr. Hite for organizing these talks and for his valuable teaching in the clinician educator concentration. I'd like to thank Dr. DeBonis for her kind introduction, and want to thank the other members of the clinician educator concentration for their feedback. And finally, I want to thank my mom and aunt, who are both Presbyterian ministers and gave me feedback on this talk. Thank you.
Thank you so much, Anne. That was a really wonderful talk. And I know we're coming up towards the end of the hour, so I just wanted to take a moment to give a few concluding remarks and really just kind of recognize the hard work that Anne, Ashley, Tiana, and Alex all put into these talks. I don't know if anybody's ever kind of done a similar exercise, but it is so much harder to do a 10-minute talk than to even give like an hour talk on something. And then the idea that we're really addressing some very complex issues here, like we covered death, grief, adolescence, substance use, race, therapy, empathy, catatonia, and I think very importantly, what happens when you give benzodiazepines to guinea pigs. Like all of these things were covered in a very short amount of time and are not easy topics to grapple with. So I wanted to really commend the work that was put in here and also really just the bravery of coming not in front of just a group of your peers, but in front of people who are more senior to you, who have more leadership positions, and being able to kind of speak from your heart and speak from what makes you feel passionate about our field. So I really just wanted to say thank you to all of you for that. Yeah, just wanted to kind of wrap up there. Yeah, I don't know if we'll have time to get to questions, but we're definitely getting some good comments coming in, just saying good work all and thank you, and just really wanted to echo those. All right. Well, thank you, Anne, Ashley, Tiana, Alex, and thank you everyone in the audience for joining today. Have a good rest of your day, okay?
Bye, y'all.
Thank you.